Started. Yeah.
Thank you. Okay.
Okay, very good. So, hello everyone. Welcome to this UKOA meeting. I'll start by introducing myself. I'm Bushra Mushtaq. I'm the new chair of UKOA, replacing Melanie, who has done fantastic work for years. And a little bit about myself. I'm a medical retina consultant, Birmingham Midland Eye Centre, Sandwell, with previous management roles and training and educational roles. And it's a pleasure to have you guys here today. We're going to talk about the role of independent sector providing NHS care now and in future. So next slide, please. So we're going to talk about this commissioned work, which is the NHS work. Just wanted to sort of make sure that we all understood the purpose. Housekeeping slides. Unless you're speaking. We will have a Q&A session at the end of presentation. So during that time, I mean, you can ask away questions. However, if you have any questions, you can put them in the chat box, which we'll be monitoring. We would like to make a request. Please, whenever you are asking a question, let us know your name, your role, and any declaration outside the NHS. At this point, I would say I just work in the NHS, just to make sure that everybody knows my declarations as well. We are recording it, this webinar, and it will be available to all the members as a link. Next slide, please. So this is a brief overview of the agenda. Johannes Keller, our chair for this meeting, would be doing, I think, a little bit more elaboration and then of various items later on in the presentation, and he will be doing all the introductions as well. Moving on to the next slide. Just a little update about the organized meetings for UKOA for the coming months. Some of them are face-to-face, well, at least one at this moment in time. So mixture of virtual and face-to-face. And the topics that we have chosen are the one recommended by our members, requested by our members, and we'll be very happy for your thoughts and ideas for any further themes that you would like to cover in future meetings, as well as any piece of work that you want to showcase, share with the members. Please put your ideas in the chat box or mail the UKOA mailbox. Next slide, please. So these are the events. Please note the dates. We have got a sort of a vacancy at this moment in time, 29th of February. We, all of you more than welcome to sort of put your name forward for any ideas that you've got for this meeting or any theme that you would like to work on. Next, please. And just a short reminder, it's a membership organization, and we would like to make sure that all the members are paying their fees, which is required for the functioning of this organization. We've got 92 members, well, 89 because 3 have declined membership. A good number have paid or planning to pay, but please make sure that you remind, and I'm sure people are, it's a process. Just speak to the person who does the payment business, remind them that this is due or overdue now. I'm going to hand over now at this point to Johannes, and he will give an introduction. He's a consultant colleague from Bristol, but he will introduce himself with all his various roles that he plays in ophthalmology. Over to you, Johannes. Thank you.
Thank you, Bushra. Thank you very much. Welcome everybody to this UKOA webinar, where the focus is on independent sector provision of NHS sector, which care, which is quite a topical topic at the moment. The UK being very interested in finding improvements and addressing innovations to improve the offering of healthcare for our ophthalmic population. So when we planned this session, we thought that it'd be interested to have an overview of how this has come about across the UK, and then we're also bringing a doctor's perspective. That's me who's going to be speaking, and then a manager's perspective. So very thankful and grateful to David Hare, who is the CEO of the Independent Healthcare Provider Network, who is going to be giving the overview, and Rebecca Light, who's Managing Director of Numedica, who's one of the leading providers of independent care in the UK. So we'll do the 3 presentations one after the other, and then we have a significant amount of time for Q&A and debate to follow, which I'm no doubt will be quite well used. So without further, I'll introduce David Hare, who is CEO of an Independent Healthcare Provider Network. Thank you, David.
Thank you, Anas, and thank you, Ushra, as well, for the invitation. Great to have the opportunity to, I think, provide a bit of a top-line summary of what's going on in the industry at the moment. In terms of slides, Carrie, are you driving those, or can I move them along?
Totally up to you. If you'd rather take control and share your own, or I can share on your behalf, whatever you'd rather.
I'll move them along. It's probably easier. So
do you want me to stop sharing and then you can reshare?
I can actually do it on this.
Or you can just take control.
Yeah, I'll take control. Perfect.
Perfect.
Flick it forward as I go. So brilliant. So in the time I've got allotted, I just want to, I guess, cover a number of areas. So first of all, a bit about us and the sector generally. Then ophthalmology activity in the context of NHS elective recovery. We know huge backlog challenges across all specialties, and just want to kind of just talk through a little about what we're seeing in ophthalmology. A little bit about the role of the sector in NHS eye care, which Johannes has quite rightly identified is clearly a topical issue for the moment. And then a few thoughts around what's next, and then clearly Q&A we can do collectively towards the end. So who are we? We're the trade body for the UK independent healthcare sector. We cover all 4 nations of the UK, have 105 members, ranging from large multinational providers all the way down to small specialist providers. About half our membership is largely acute, so hospital and surgical activity, covering both NHS funded and privately funded care. But we also have a range of members in community diagnostics, primary, etc. It's about a £16 billion market in the UK, so quite considerable, although clearly small compared to the NHS. Looking sort of more broadly across the sector, members and virtually every kind of major independent sector provider is a member of IHPN. We employ or contract with over 150,000 staff, services delivered from 800 sites across the UK. Gives you an idea in terms of the kind of overall quantum of scans and tests on the diagnostics side. And when it comes to CQC, as well, just over 9 in 10 rated good or outstanding by the CQC, actually rises to 94% when you look at independent IHPN members. So it is a broad and deep industry delivering care to private and NHS patients across the UK. So in terms of elective recovery, I haven't had time to update this. Can you not see slides?
Yes, it was simply stuck on the.
Yeah, okay. Carrie, can you move them forward? I don't know which one you can see at the moment. Can you see the? Sorry, Carrie, which slides can you see?
So we were still sitting on the membership status, I think. So I don't think they were moving along outward facing, if that makes sense. Do you want me to stop sharing and then you could share?
Yeah, that sounds a good idea. Let's try that. Is that better, Carrie?
You can see your screen now, David. Yeah.
Brill, excellent, perfect. So okay, so hopefully colleagues have seen this slide. Just in terms of the breadth of membership, hopefully this is now beginning to flick through. So what I've got in front of me now is the sort of overview of number of individuals employed or contracted, number of sites, etc., which I just talked through a moment ago. So moving on to where I paused a second ago. So in terms of where we are in NHS elective recovery, I haven't had a chance to update the latest data which came out yesterday for August, but I think we can safely say from headline kind of coverage that it's largely sort of deteriorated headline levels since then. So overall record high waiting list, 7.75 million, I think, as of August. You know, obviously people waiting considerably longer than pre-pandemic, including nearly 400,000 people in total, 5% of the total list, waiting longer than 12 months for treatment. That would have been in the low to mid hundreds back in 2019. Overall activity levels, like I say, across all specialties, most recent data up on 2022 levels, but still overall down 14% compared with 2019 levels. So that real struggle to try to catch up with overall levels of activity post-pandemic, and then clearly challenges as well in urgent referrals and also in A&E. So pretty much everything flashing red, as any of us know who are working in the healthcare system at the moment. In terms of, again, this is aggregate headline, not specifically about ophthalmology yet, but the independent sector kind of contribution. Overall share of admitted activity across all specialties is now 18%. So that's nearly 1 in 5 NHS patients for admitted care being seen in an independent sector provider in some form, and of non-admitted, that's 7%, and higher than 2022 and 2019. Delivering around 2,500 admitted and 4,000 non-admitted RTT pathways per day, and that overall independent sector activity is up based on RTT data 21% compared with 2019. So the sector overall doing more, driven, and I think clearly of direct relevance for this conversation, principally by a significant increase in the amount of NHS funded ophthalmology work, up 162%. It is up slightly in trauma and orthopedics, but actually down in some other specialties. And I've just drawn out gastro as an example there, where actually IS NHS funded activity is down 40% on where it was in 2019. So in terms of the role of the sector in NHS eye care, I think we need to acknowledge that rapid pace of change, that quite dramatic increase in activity that's being delivered. You see the numbers there. In January 2019, the sector delivered 13,000 ophthalmology pathways. In January 2023, it was 37,000. So a significant increase in the amount of activity that's being done, and that change of pace and speed inevitably, brings focus into the conversation, but also significant benefits, and I'll come on to that in a moment. The bedrock, I think, of the sector's focus on NHS service delivery has to be quality. I'm sure we're all aligned on that. We have a kind of key tenet of the approach we take within IHPM, which is the sector does not compete on safety, and we've got a very active work programme around supporting the sector to deliver the safest possible care. Our medical practitioners assurance framework, looking at clinical governance in the sector, is now an integral part of the NHS standard contract from this year. It's also part of the CQC inspection regime used when the CQC go and look at any independent sector provider, particularly in terms of clinical governance. We run a number of learning and sharing programs throughout the year, including our annual patient safety conference, which is held jointly with the CQC. So a sort of major ongoing focus around quality and safety. 98% of independent sector ophthalmology sites currently rated good or outstanding by the CQC. Another data there, I think, indicating quality and safety across the industry, but inevitably always more to do. Here's just some information around workforce and training. 992 specialist ophthalmology consultants currently active within the sector, according to the private healthcare information network, which collects this data. Over 1,000 nurses employed by ophthalmology specialist IS providers. And of course, growing numbers of healthcare professionals being trained in the sector. I'll come on to that more, and I'm sure that'll be part of the discussion as well when we come on to that at the end. But the sector absolutely recognises its responsibilities to training, particularly given the overall volume changes that I've just described. In terms of that impact and what that means in terms of ophthalmology. I think this is quite an interesting interesting kind of chart. We know there are pressures everywhere across the system, including in ophthalmology, but actually ophthalmology now is one of the only major specialties which is delivering more overall activity than prior to the pandemic. Here's the sort of January 20 to July 23 data, and what that means in terms of the average waiting time. Again, ophthalmology is the only specialty where that has actually come down from where it was pre-pandemic, so those activity levels are clearly benefiting, and then that just gives you a bit of an indication in terms of waiting times by sector and by independent sector and by NHS and an aggregate as well. So what's next? I think it very much feels at the moment like the policy direction of travel is towards patient choice. Some of you may have seen the Prime Minister's Elective Recovery Task Force, which I sat on, a number of other colleagues across the NHS and the independent sector, recommending that patients should have a minimum of 5 providers to choose from in receiving their NHS funded care. My understanding at the moment across all specialties is that average is about 1.5, so quite a lot to do to try to drive that. Currently, only 1 in 10 patients are known to exercise their right to choose a provider at the point of referral. This plan is designed to try to increase that, and then patient association work looking at what that would mean in practice. So we know that many patients are willing to travel. 3/4 of them would be willing to travel more than 30 minutes to access treatment more quickly, and the average distance a patient would need to travel is just 13 miles to reduce their waiting time by 3 months. And I think it's probably worth saying, given where the polls are and the political dynamic at the moment, the Labour Party have indicated that this would be something they would press on with as well. So I don't think there's a huge political divide in terms of the direction of travel for patient choice for NHS funded services. So in terms of working as a system, the kind of integration aspect, I think absolutely know the NHS and the independent sector share the same goal, which is a sustainable eye care system benefiting patients. We need to work collaboratively and are looking to very much do that. As I said, patient choice likely to remain a core part of the journey. Indeed, I would expect that to build momentum over the coming months and years, and indeed there's due to be a major patient choice public information campaign starting in November, and a number of sort of assurance frameworks being pushed through ICBs to make sure patient choice is being offered, blending therefore the need for a degree of competition but also collaboration, and we need to get that balance right. But of course, acknowledging the challenges facing eye care, a limited workforce, limited funding pot, the ability to kind of manage the integration that I've just described, plus of course just managing those supply chains. And then just sort of trying to address some of the challenges. We know the financial sustainability of services is pressured. Times was reporting this morning, NHS England going to Treasury to look for around about £1 billion extra funding to deal with the financial costs of strikes. We know that funding is pressured, but we also know there are some particular challenges with how tariffs are set for eye care services. So are there things we need to look to do there? Case complexity. Are we getting the balance right? Are there ways in which the independent sector providers can be supported to deliver more complex care, and how are we managing the complications and follow-ups challenges across the system as well as a single system, and how can we make sure, and I've sort of touched on this throughout, we make sure that particularly the barriers for junior doctors accessing placements with independent providers are removed, giving as much opportunity as possible. How do we make sure the funding flows properly? How do we make sure the oversight is done, etc.? And I'm sure Rebecca will come on to describe a little bit about how that's being done in one provider in New Medica. And then sort of continuing that theme of collaboration, making sure that we're all committed to working collaboratively to deliver the best possible outcome for patients overall. So I'll pause there, Johannes. Hopefully that's a good sort of general trot through of the issues, but looking forward to getting into the debate later with Q&A.
Thanks very much, Nick. And now I'm going to share my slides. And hopefully you can see them now. I think you can. So excellent. So we started with an overview from a high-level grouping of organizations. So now I thought I'll give a single doctor's perspective of what it's like to work in the independent sector. So my name is Johan Keller. I work in Numerica and I'm a director of the local center. And I also work with the Numerica holding organization. These are my disclosures, and the relevant ones is that I'm employed by Numerica. I also work in the NHS, and I've received grants and consultancy agreement with other providers. So I'll break this down, David has already given an excellent background of where we are at the moment. I'll give a little perspective from being a doctor, and then I'll just go straight into matter of what it's like for one consultant, and I'll describe my Numerica journey. So what it is like to see and operate on patients there, then what it is like to set up and run registrar training. And one key aspect of what's interesting about independent sector work from my perspective, which is service development. And I'll give 3 examples. One is the introduction of VR service to my practice and to the group as a whole, then building a community surgical center and formalizing the way of planning for refractive surgery or the refractive aspects of cataract surgery. And finally, I'll touch on management of clinical governance in this setup. So I'll tell you a little bit about me. I was born overseas. I'm Venezuelan. I came to the UK back, a while ago, when the landscape was completely different. With the notion of specialized, this is very common from my background. And at this stage, there was a massive influx of people coming to get senior sales officer jobs. I found this quite difficult. It took me 350 applications to get a job, but eventually I did in 2004. Did the old style MRC off training that many of you would have done, and others go straight into training. But then further changes meant that I got stuck in modernized medical careers, and that made me leave the UK again and open my horizons widely. So I moved to Spain to start from the beginning, and that also gave me the opportunity to see very different situations, because in Spain you get the opportunity to rotate outside, and I could go to India, Switzerland, and somewhere in Spain. After that, I did fellowship training. I did in the UK VR. I was already a fellow of the Royal College, so that was, logical. And then Australia, further wider experience. And then at the time of getting consultant jobs, as it happens, a very good opening came up in Bristol, which I took. There were other opportunities, so that was the one that I found was best. And as it happens, Bristol is the birthplace of Numerica, so it followed that I started working with Numerica, and I became a partner in 2021 and got a role in the Medical Advisory Committee in 2022. So this is the logos of the groups I work for. You can see lots of NHS logos there, and plenty of others in the UK private sector and elsewhere, public and both private. So that sets the scene of how you can move from one position to another. And note that this is a way of giving healthcare. So David already spoke about what's been happening and where we are now, and this has caused quite a lot of disruption to the way we work, which has been spurred by the pandemic and the lockdowns that were imposed to deal with it. And I'm just showing you the titles of several reports, many led by the Royal College of Ophthalmologists, but also by think tanks that analyze how healthcare provision has changed in the UK from this. So what is this independent sector? This comes from the policy introduced by several governments ago to allow independent groupings to offer NHS care using a contract. So essentially, these are businesses, and as such, they need to be profitable to function, and this means that you can fail. So that sharpens the focus to ensure that you can deliver a quality service and attract patients. As such, there isn't agreed collective bargaining contract, so there's no consultant contract. Various providers have their own arrangements. Essentially, generally, consultants are paid per activity. This generates a labor market, and so all the staff are paid at that rate. But also, there's the additional benefit landscape is different. There's no NHS pension. There are different perks, because staff is the most important asset of any enterprise, particularly for businesses, and the training of staff is well developed. But we acknowledge that training of registrar doctors is evolving. We have made quite a bit of an improvement here. I'll hope to show you later. And the resource constraint is quite obvious to someone who is delivering the service and organizing it. For example, setting up services giving general anesthesia in the eye care. At the same time, there's a lot of similarity. David alluded to our common goal, giving sustainable quality care. So the patients are the same, and they come with the same requirement for good quality care. The regulatory framework is the same. So doctors are regulated by the GMC, NHS delivery practice is regulated by NICE, care is commissioned by ICB, the quality of care is monitored by the CQC, and the technical aspects of NHS England are implemented in the same way. A cataract operation is a cataract operation, whether it's done in an NHS hospital or elsewhere. So the technical part of it is the same. And indeed, you're managing a human workforce. So those challenges and benefits are there either side. So essentially, most services focus on cataract surgery. Numerica is focused on primary care because of the philosophy of where it was, how it was developed. In fact, Numerica started as a glaucoma pathway improvement, and it has now developed into primary care. But this is a mechanism, so there's potential to develop other services, and we have, and I'll show you that later. Consultants are engaged either as in a service agreement rather than employment, or given a high salary, or have the option to take a stake in the business, like in Numerica. There are various proportions of permanent and bank staff, and various degrees of complexity. In Numerica, we believe that the degree of complexity is limited by the setup. Therefore, we undertake routinely complex surgical cases. But a strong value is that we must be efficient. So we manage the case mix and segregate lists to improve the total throughput. There is a wide employment of extended role practitioners, both nurses and optometrists, in outpatients and theatre. We've got the opportunity to design the space to follow workflows rather than to adapt space to patient requirements. Because it's a business, the business managers are employed and sharply focused on management of the process, which means that you're constantly looking for improvement to make your process more efficient and continue to deliver a high quality. And because we're large organizations that are quite fluid, we have it fairly easy to share the learning across all with the principle of delivering lean care as only in the needed patient interactions that are required. From the doctor perspective, that gives you more flexibility. You can organize your timetable more easily. It gives you more autonomy, I guess, in experience with working in the NHS. But obviously, there's constraints to everything, and the more complex you get, then the more constraints you develop. And pay is overall higher. However, as a disadvantage, you have worse job security because, like I said, this can fail or can be limited by the success or not of the business. And it's impossible really to match the advantage of the NHS pension and the benefits that public sector employment has. There's also limited availability and scope of work. I mean, my core training is complex regard surgery. This is currently not viable in the independent sector, so that doesn't happen. But again, it's finding how you can use the resources that are available to make it work for the work that's needed. I guess in great part for the disruption this has caused, but also because of the philosophy of it, we recognize that this is unpopular with some colleagues, and we have to accept that. And it must be profitable. If it isn't profitable, then you find yourself in situations having to lay off staff or curtail services and find safety for patients. Numerica Bristol itself was initially founded in 2007 with any qualified provider policy, and this was founded by one patient and a doctor who sat together to try and see if they could find ways of delivering care, NHS care, in a more efficient way, and took advantage of what was then the government policy at the time. And in 2016, the Specsavers Group, the umbrella organization, Specsavers is the most known brand there, took a 50% stake, which was 100% in 2001, and Numerica is now a standalone company within this group. And that replicates the Specsavers way of organizing work, which is in joint venture partnerships. So each Numerica you see is run by a group of local clinicians and business managers with an overarching organization that does back of house and complex management interventions. Bristol was the second group to be launched as a partnership with the opening of a medical center in Litfield House, which is a medical center in Bristol and is still one of our centers. Then we identified outpatient demand in a rural area south of Bristol, and so we opened a clinic in the premises in Langford, which is near Somerset Levels, and then further expansion towards the east in an area that is fairly rural, sparsely populated, but not directly served by hospitals. So that gave us the opportunity to open a center, which we have now closed because of reasons outside our control, which brings into relief the fact that there's always elements in delivering independent sector care that put you at a disadvantage with an established state operator. But eventually, becoming established as a standard provider of ophthalmology care in the city of Bristol, we developed our own premises, which you can see photographs here. We designed and built, with the support of Numerica Central, a dedicated surgical service. And you can see a photograph of our first patient, our theatre group, and the inauguration event. So currently, we have 4 partners. There's 3 consultant ophthalmologists and 1 business manager who work together with 21 ophthalmologists. That gives us 8 full-time equivalent ophthalmic doctor care, 7 optometrists, 3-time full-time equivalent, 31 nurses, and support admin and management staff. We're centered in a purpose-built hub that was developed with our input, and we designed and interface with project management on how to organize to benefit our patient pathway. And yes, cataract surgery is the core of our work. It's currently 60 to 70%. We do not do pediatric ophthalmology, so we don't operate children. We do not have facilities for general anesthesia, and we have no beds. But otherwise, we undertake traumatic black and white cataract surgery, patients with phacomenesis, and complex surgery. We also have a sizable portfolio of glaucoma patients. Obviously, we're a primary care provider, so we're not a surgical glaucoma team. Therefore, we focus on patients with low complexity or stable. We have a small oculoplastic primary care service that deals with malposition and minor ops. And we've instituted a vitreoretinal service mostly to manage complications of cataract surgery in-house. And that also allows us to offer a small area of private surgery. So this is how it works day to day. We try to streamline and be as efficient as we can and provide a good patient experience. So cataract surgery is single stop. I told you there are 5 restrictions. With agreement with the local trust, we do not take patients that have had trabeculectomy because the local surgical glaucoma team want to manage them. And no one that you cannot operate in a standalone surgical center that's not attached to a hospital, but otherwise, all comers. Our standard pathway is a 3-stop pathway with a technician, then followed by optometrist and nurse, and then a doctor and advanced practitioner, where the general ocular health is assessed, and then all the tests are ready. So the patient is at the point of finishing this clinic, ready for surgery. So this is the first stop: OCT, biometry, visual acuity measurement by a technician. Then right next to it, there is another room for optometry or nurse, check pressure, check the anterior segment, topography if necessary, refraction if necessary, and then the advanced practitioner or doctor who completes the pathway. Our glaucoma pathway has 2 pathways. Originally in 2007, part of the innovation of Numerica was set up an optometrist-led clinic where paraclinical testing was done, and there was an optometrist decision for each patient, and then there was 100% extemporaneous consultant review, and that produces a monthly assurance report. And we also have a doctor-led pathway. It's unstable, meaning someone who needs a medical intervention, where a patient gets checked in, get visual acuity and visual field testing, then goes for a TEG or an optom to check the OCT anterior segment and pressure, and then a doctor for gonioscopy, dilatation assessments in the fundus, and treatment plan. And then pathways are interchangeable. Obviously, if someone is becoming unstable, sees a doctor. If someone becomes stable, moves to the optometrist pathway. And in cataract surgery, we developed a dedicated theatre, which is streamlined. It's got a very small footpath. So there's a reception area and then an area for examination and meeting the doctor. Then moves on to the theatre, which is fully equipped, modern, clean, which allows cataract surgery and any surgery that you can do bilaterally. And then a discharge lounge. So patients are ready for surgery. Currently, we're managing turnaround times, complete turnaround times of 20 to 24 minutes. And also another advantage of working in this environment is that we have a protocolized management. So down to how a complication is managed can be replicated across the service throughout the country. And on average, patients spend 45 minutes in the facility. So now about developing the service. So this is how we managed to bring registrars to our centers. This became of age with the pandemic and the lockdown, which greatly disadvantaged trainees. So a framework to bring trainees to the independent sector was required, and this was published by Health Education England in December 2020. And that also instituted a regulatory framework for each NHS trust that will undertake this. Numerica made this into a policy that was published and made into effect in June 2021. And the first trainees finally came to clinics in September 2021. So it took 6 months to get this going. Imagine you are aware with the guidance that the college has produced, both to train in high volume cataract surgery setups and in the independent sector. I'm proud that Bristol is one of the case studies in this guidance. So what's in the Health Education England guidance? So it tells us the rationale of doing this, and the scope is limited to trainees that are in a training program. It also decides how this is funded, and it's partially the trust employing and partially the Health Education England. And it limits the contracting of trainees by trusts. Also, the funding of educational activity via deaneries that respond to Education England, and establishes how not just the clinical governance or the management of the quality of care, but also the output of the educational governance is set up, and set up what the trainees' responsibilities are and a framework for indemnity. So our policy involves the sites that have doctors in training. We've agreed that we continue with the Health Education England policy, so salaries paid by NHS and the deanery. The costs to the practice are agreed by each of the joint venture partnerships, that the services continue to accrue funding from the activity. We take NHS doctors with numbers only. We provide a clinical supervisor, but request the educational supervisor remains that of the deanery. We follow with the statutory regulation of the CQC and manage carry out employment checks as any new member staff would do. And it is required that our sites are registered with the GMC. This is one of the biggest barriers for us to start, I guess partly for lack of information. So you would engage staff from the deanery, staff from NHS hospitals, and they were not quite clear how this was done. Eventually, we managed to get that and get agreements with the local deanery that allows to get the first trainee. And this is now published by the college and set up the minimum requirements, which are partly to do with equipment and greatly to do with how this is going to be done, to whom and whose responsibilities there are. Crucially, having a clinical supervisor and a mentor to the trainee is fundamental. So this is a photograph of our first registrar, who is in rotation with the Bristol Eye Hospital as part of the medical retina rotation that didn't have any surgical exposure. We designed a local training program and a surgical logbook that included a referral for each case and each event. At the time, we were under a lot of service pressure. We introduced Monday morning surgery and a program for directed deliberate simulated practice with a Keystone simulation kit we bought. And Stuart did his first operation on the 20th of September 2021. And we followed the local rotation, so trainees change over in August and February. So he did 14 sessions. There were 28 cases. There was one capsular rupture. When you look at statistically, this is within what you expect. And there was one late IL dislocation. I wouldn't say this is a complication because it was of extreme mild with previous vitrectomy. Since then, this has become quite well embedded in our practice. There's a program that we've shown to improve the skill acquisition of trainees. We've now had 4 trainees going through, one of them repeated terms, so we have 4 terms and we have a training in place. And the outcomes are excellent. We emphasize learning of efficiency, so we don't have delays to list because the training is going on. Since that complication, we haven't had any more instances of vitreous loss or capsular rupture. And the feedback we get from trainees is very good. The wider Numerica, there's now a clinical lead consultant who is a national lead for training. The HR the team is very attuned of how to onboard trainees. 14 of our 19 practices have at least one registrar at any one time, and there's a commitment for the remaining 5 to also take registrars. In Bristol, as well as training, we carry out teaching. So we've been doing cataract surgery seminars, and we do this biannually. We do this in our facility, and the commitment is to continue these ongoing. We've done 2 all-day VR teaching sections, also because I'm a VR lead in the hospital, but you know, we've got a facility, so why not use them? And we've done 1 anterior vitrectomy and complex cataract surgery training simulation day. That's the photograph you see with industry partners, and the commitment is to carry on doing this annually. So 3 other stories briefly. We identified quickly that vitrectomy surgery would be useful, so we set up a task group. I was appointed clinical lead. We developed the pathway, the documents, the business side of it, how to procure to make it viable. And the first vitrectomy was done on the 24th of November 2020, and now this is a modular option. Some practices benefit from vitrectomy, some others don't. Some have excellent relationship with the local VR team and refer, others do it in-house. But this is there, you know, to me, show me, this happened at the point where I decided to become a partner, and show me that it gave me the tools to do this service development quite well. So that was really attractive to me. We've had a number of instances where the refractive planning of cataract surgery wasn't great, and our private offering has also increased, which gave us the ability to treat presbyopia and astigmatism. So we did a pilot study adapting the industry standard for refractive preference data collection. We did a pilot, introduced some refinements. We did this in October, and by April 2023, so a few months later, it was also implemented across practices. And I guess the jewel on the crown was building that community center. So we identified that the demand for our services was great. It was much more important that the resources that we had available. So we wrote a business case drawing epidemiological and business data. This was done in June 2021. Then assembled a project management team with various multidisciplinary teams. Crucially, it had a lot of input from the clinicians at the front and the manager of clinical practice, theatre management, outpatient management, procure equipment. And in just over a year, this was open, up and running. And this is how it works. I'm particularly proud of this. This is the theatre that I showed you in the video, and I had a hand in helping how this was. Obviously, this was done by an architect and a team of builders, but that's the pathway. So, and the theatre follows the pathway rather than the other way around. So first get admission, then get meeting of the doctor. At this point, the patient's already ready for surgery. So it's really the handover, choosing the lens, coming for surgery, surgery is carried out, and then the discharge happens, and that's it. Clinical governance is fundamental. I've got quite a bit of experience in this in the NHS, and now I'm applying this in the independent sector. Each practice in Numerica has a local governance structure. So all partners, also all the clinicians and business managers of the company are directors. Therefore, under Regulation 5 of the CQC, are accountable for the quality of service. We also have a designated registered manager and nominated individual, and in practice, this is a partner. Depending on the size of the practice, some employ governance managers, all others are, these functions are done by the directors. And we have established monthly meetings that look at incident risk, learning, and improving quality and clinical assurance. And we report to the central structure, where Numerica is the accountable body, is a board of directors, and the medical advisory committee directly reports to the board of directors. So there's a monthly meeting that monitors complications, complaints, and incidents. There's a dedicated capsular complication and a dedicated endophthalmitis watch, and each incident triggers an investigation that is a standard to the company. We make assurances that our staff are suitable, and MAC has the authority of developing and implementing safe and effective treatment, and is also in charge of managing serious incidents, never events, and now implementing the PCIFR methodology. So this produces a yearly quality report. You can see that here the headline indicators and the focuses of where we'll go next in terms of developing quality and safe care. So to my mind, just like David said, both NHS and independent sector providers of NHS care have the same objective of delivering good quality care, and we're both means to reach this end. And it's finding that balance of competition that motivates us to find improvements with collaboration to ensure sustainability that needs to be organized. My view in terms of training is that training should be an activity in itself rather than an attachment to service, because the quality of care that we deliver to a patient should not be compromised by the practitioner delivering that care being a trainee. So I don't think we should accept that the care of a patient is diminished by the fact that the care is in training. So it is to us, to the trainers, to ensure that care is organized in a way that it doesn't matter that you have a aircraft pilot that's just starting or a very senior captain, that plane lands safely every time. So the question, I guess, we have in the end is how we can ensure that us as ophthalmologists can work collaboratively to use best of the resources that we have. So in my view, the independent sector is a contribution to fix the productivity problem, but it's not a single solution. We must all adapt and compete and collaborate. We're not inventing new things. Yes, of course, there's always innovation that makes marginal gains, but we know that we need to use resources well, that we need to manage our resources and have a good leadership to reach an end. And for that, it's fundamental that our staff are motivated to have high morale, and ideally that we control some of the incentives to tweak the behavior to get to that end. That's all I wanted to tell you today. I've run very slightly. So I will then introduce Rebecca Light, who is the Managing Director of Numerica, the overarching organization of Numerica. And hi, Rebecca, thank you.
Hi there. Hi
agreeing to speak to us. These are the topics you sent me earlier.
Great, thank you very much, Johan. You're a fabulous example of one of our partners at Numerica, sort of showcasing what we do, so thank you. So my name's Rebecca Lythe. As Johan says, I'm the Managing Director at Numerica. I've been in the role for 3 years. I don't have a healthcare background, so my role is really all about managing people and making sure that we're doing the best for our patients and being really part of the solution as we've described, as Johan has just described. That's what we're really all about. And our vision actually at Numerica is really about changing lives through better eye health and eye care. So that's what we do every day. We want to just make a difference. The things I've picked out to discuss here, sort of knowing that the audience and the reason why you're all here as part of this membership group, I believe is around driving efficiency and driving quality. And I thought I'd pick up on some points here, a little bit about the ownership of different independent sector providers, because I think different providers come at it for a different reason. We've got patient choice, which David's already described, so I won't dwell on that too long. And then I just talk about, some of the management challenges that I certainly see, but I think I would say I'm sure many of my colleagues in different organisations also see. So we'll pick up some of those things because I think collaboratively together we will get to a better place. So first of all, about the ownership. Numerica is a private business. It's family owned, as Johan has described. It is part of the Specsavers Group, which is a family owned business, and we're lucky in that respect. And it's got a very, very long range, view. in terms of the investment and the support that we receive at New Medica, which I'm extremely grateful for. It means we can go at risk. Johan's just described the building that they built in Bristol. That is all at our own risk. But we've got a long-term view of it, which is very, very helpful. There's no knee-jerking or different directions. But other independent sector providers, they'll have different funding arrangements. Quite often might be private equity. And again, they'll have a different view. They'll be in a different stage of their cycle, perhaps, in terms of their investment. They'll be part of maybe a bigger portfolio with different competing needs. So I think that's just, quite often we get bundled up in it's the independent sector, but actually the funding arrangements will be different with different time horizons. So anyway, that's just something to sort of bear in mind as you think about us. Patient choice. As a manager of this business, patient choice is fundamental to everything and how we think about it, particularly in how we support our referring community, but also how we support patients. It's an open market. And so we're continually thinking, and we've done lots of research around this to go, what is it our referrers really need? They've got such a short moment of time to make a difference for the customer, whether it's Vision Express or Boots or Specsavers, whoever, the GP. They've got such a short time to actually say, look, I'm going to refer you. And what do you need in this moment? What's going to be most important to you? And how do we help support that conversation around choice? And there are many choices. We know that most referrers have at least 5 places that they can refer that customer to. And of course, we want to support that choice conversation and help that. So we talk to our referrers a lot and we say, what do you need? And they also need support to develop as well. The referrers are looking for, how do you support me and my team? So we think about that too. But supporting patients, it will be in that moment, well, where do I need to go? And we know that they want short waiting times. They want clearly great care. They might need help with transport. They need to know they can park. Can they take a carer with them? These are the immediate practical things that are most important. And then once they've got all those practical things, then they get into, gosh, what's going to happen? And so actually we're just refreshing some of our materials to really help that conversation, because we know that patient choice will be really critical, and a government campaign hopefully in the next few months. But what I'm describing, I guess, is it's not a B2C marketing. It's very much a B2B, and we have to really, really think about the referrer and the patient as we're preparing materials. So that's what I'm thinking about. I'm thinking about the marketing, I'm thinking about the research, I'm thinking about what would be most important in the moment for these individuals. Management challenges. I think we've already heard a few here. So it is a competitive market. And I think that's a good thing, because I'm always thinking, as I've just said, what is it that the patient is going to be really, really needing? And actually, if I look across all the independent sector providers, our competitors do an amazing job at this. I mean, Spa Medica do a fantastic job on their website, really describing the journey for their patients and providing literature. And I think that's an amazing thing. That really is raising the bar to help patients. And that helps all of us. If somebody does a great job, that helps the whole of the sector. But it's definitely a competitive market. Everyone does some things slightly differently. And I think, but the whole thing is the bar is continually raising. And I think that's a good thing. Workforce. So we know it's a huge challenge across the NHS, and obviously we've talked quite a bit of it already today about the ophthalmology workforce. Ophthalmology, the ophthalmologists themselves is in short supply. Then you get into scrub nurses, you get into nursing, you get into optometrists, you name it. Everywhere we go, there is a demand. And so the way we think about it is, I sort of describe it as we need to be able to, where we can, stand on our own and think about a 5-year plan in the future, and what does that mean? And so at every point, we're looking at, okay, how do we develop our optometrists? How can we support our businesses, like Johan being one of our business partners? How can I support him with some money to go on and develop that optometrist? And that's something that we're thinking about quite closely at the moment. We've developed our own scrub tech programs, and we've got that out in our businesses that we can grow our own. And so for every single layer in our business, we are looking at how do you take a retailer that might have been working in Sainsbury's and how can we switch them into healthcare? And we've got lots and lots of examples of people that are coming into the sector at the beginning of their career, and we're trying to give them a ladder all the way up. And we call it the New Medica Academy because we really believe we have got to be part of the solution to build healthcare for the future and build our own. And so we're trying to develop all of these plans, the training plans and the career ladders in order to do that. And hopefully they will stay with us, they will learn, they'll have an exciting career. But we think the accountability has to stick with us rather than from taking, as has been the charge from many places, that we're just taking nurses from the NHS who are already extremely busy, as you all know. So that's our mission. Lots to do. It's a really long-term game, but we think it's really important. The other area is around technology. As you know, as we all read all the time, technology is changing. And I think it's all down to the fact that resource is extremely scarce and will be scarcer as people start to retire and change. And, you know, obviously what we see is certainly from the big suppliers, if I take Alcon or B&L, they're all about trying to look at the theatre suite, or the OR as they describe it, take the theatre suite and start to integrate all the bits of devices and make it the most efficient it can be. So that is the sort of direction of travel. AI, as we know, will also contribute to that, and we're not quite sure how that will play yet. But I think there's something for us here in the independent sector where we can be really testing and trialing and moving this agenda on that can, I think, benefit, again, everybody. If we've got some money here to do it, we should be investing in this way and then sharing that and trying to develop it going forward. So that's an area that I think is very interesting. It's just going to keep and develop. I don't know what direction it will go in. We've got to work with the NHS as well. And of course, the NHS Digital has a huge agenda, and we're trying to keep pace with that at the same time. But I think there's a great role there for independent sector to drive this forward, learn, and we can share our learnings. Sustainability is another area, and I'm really talking here about not just what we can do in terms of health inequalities, but particularly around carbon reduction. I think most people have got their heads around scope 1 and 2 quite nicely. They've moved to green electricity. They've sort of, you know, we really try and find buildings that haven't got gas. And if we do, then we've got to try and work our way through converting that gas to a sustainable heat source. So scope 1 and 2 is sort of, we've got our heads around. It's scope 3 where I think we've got a job, and I'm saying we about New Medica, to really work with our suppliers and really challenge them to think quite differently around what are they doing around their mileage, the packaging, you name it. I think there is so much work that we can do there. And it starts with us to look at our theatre packs, our theatre listing, what we're doing, but then work with our suppliers more collaboratively to get a solution for the future. They're learning as well. They've got their heads around scope 1 and 2, and they're also grappling with scope 3, but that's where it's going to be.
Rebecca, you've gone muted.
You need to unmute yourself.
Sorry, when did you last hear me?
60 seconds.
Sorry, say that again?
About 1 minute ago, it went mute.
Oh, okay. You did catch the tail end of sustainability, hopefully. The last point I was going to make is just, you know, how are we part of the solution in every community? And that starts with the discussions we have with ICBs. It just starts with the need. Ideally, we're trying to get as full scope as we can, take as much complexity as we can, but it does depend on, for New Medica, it depends on the partnership model we've got, the specialisms that we've got. We try and get glaucoma in every single service because we know that's an area that we could hopefully make a big support and impact on as well and help the whole system. So that's our philosophy. I think hopefully you can hear that we are trying to work in tandem, grow our own, and also share some learnings as we move forward as a business. But really keen to take questions, as I'm sure Johan and David are as well.
Thank you very much, Rebecca. So that is then the presentation side of the session. I hope that was informative and useful to our UKOA members. So yes, let's move on to questions. I have a question in the chat from Andy Miller. Any info training of other healthcare professionals? Yes, this is in fact quite developed. We have pathways for training of, we take pre-reg optometrists. Sorry, I can only speak for New Medica because this is where I work, right? But we do take pre-reg optometrists. We have established optometric practice within our teams. We have a scrub practitioner program as well, and we train, like Rebecca said, from retail to be ophthalmic assistants to an ophthalmic technician program. So yeah, this is quite well developed. Ben, you have a question.
Yes, Ben Burton, I'm the president of the Royal College of Ophthalmologists. Thank you for some great talks, and really pleasing to hear that you're taking the training seriously. My concern is not with the independent sector per se, but the kind of what is the end game. And it seems to me likely that more and more of the ophthalmic services will become provided by independent providers, to the point which either the money will run out or the number of consultants will run out in some sectors, as we're already seeing in paediatric ophthalmology and glaucoma. And I think services will collapse and become non-available, and then the massive increase in the amount of cataracts we're doing is going to kind of drain the funds for the rest of eye care. Where do you see things in 5 and 10 years' time? My vision is that we'll have it mostly provided by independent providers. The money won't be enough for you to make a profit. You'll stop doing it for the NHS and just become a private practice service. And we'll have lost the NHS ophthalmology offering in much the same way as we've lost dentistry. Is that inevitable? Is that where you want to think things should end up, or do you have another vision that's different to that? Thank you.
I hope it doesn't come to that. I think it'd be interesting to see how we develop in terms of other people starting to do other services as well. So could come a broader healthcare provider. I know some of the people are starting to work like that. Czech, for example, I know do different services. So that's another way of, let's say, balancing the books from our point of view as things change over time. I would hope that we find a relationship around who does what, how we can work together. There's a growing aging population. And I think that's important that we understand on a local level what's required. So for me, we've got to get down into the detail of what is required and what the skills are available across the piece at a local level.
Sure. I mean, there's plenty of patients, there's plenty of work, there just isn't plenty of money, and there isn't plenty of staff. So I'm just wondering if where we're going with this is the best use of, having a choice of 6 different cataract providers is lovely if you can afford it and you've got enough staff and nurses and so on to staff 6 theatres and 6 consultants going hell for leather. But if you're a glaucoma patient at the moment and you've got a choice of either going blind or waiting 3 years to be seen on on the NHS as currently available, or you go privately, that's not a great choice. Are we prioritising very mild cataracts now ahead of people going blind on NHS waiting lists? It just doesn't seem I'm not saying it's your fault or New Medica's fault. I think it's the way it's been commissioned as not being good. but it seems very difficult to change the commissioning and do anything about it. I just wonder if New Medica had a vision when you're competing against 6 other groups, and when the tariff kind of becomes non-viable for many of the services that you're offering.
Well, who knows what the tariff will do? So I don't know, Ben. I mean, clearly, as a commercial organisation, you'd have to adjust and do things differently. We tend to think of ourselves as a broad ophthalmology provider. We don't want to be seen as a cataract factory. And at the moment, clearly we're doing a lot of cataract work because that's where the backlogs have been, and we want to try and swing and support and get a balance. So that's how we see ourselves moving. We don't cherry pick either. I wouldn't say we do that across the piece. We take more complexity, and Johan, you might be able to answer this in your own service. So that is also really important to us.
I guess if I can come in, so there is a population based need, and there's an individual patient based need, and from the clinician perspective, you satisfy the needs of healthcare provision of that individual patient. I think it'd be wrong to say that you are not going to operate someone with retinal detachment because there are so many patients that need cataract surgery. At the same time, I don't think it's reasonable for us to say because we operate retinal detachments, then we're going to limit provision for one service or the other. This is clearly outside New Medica's scope for resolving, other than to react to a landscape where we can provide for the service that for patients that need our services. Yes, it's very notable that certain services are much more challenging to provide than others. And definitely for a sustainable system to cater for the needs of all these patients, collaboration agreement is needed. Now, you paint a scenario that's quite scary. You wouldn't want the situation of ophthalmology to end up like it has been with dentistry, but we can also look at the provision of optometry care, where a provision is much wider and is entirely private. It's entirely private with NHS funding. What I'm trying to say is that there's no determination that we'll end up in one scenario or the other. It's up to us as a community, and obviously for the government to decide where we want these services to be in. I keep telling my partners, my colleagues, my staff that the Bristol Eye Hospital, though, is my first consultant employment, has been here for 300 years, and I want New Medica to be there 300 years hence, because it's part of the way I think care will be delivered in a way that focuses on the patient needs. Alison, you have your hand up.
I did, thank you. Really interesting slides and presentations, so thank you, and hopefully dispel some of the myths around some of the independent sector provision. So my question is possibly for you, David. Sorry to put you on the spot, but you may know more than others, is whether or not there are some strategic conversations going on and planning really about the future demand and capacity required for the delivery of, let's focus on cataract for the time being, because obviously the real shift in moving to the independent sector sort of post-COVID was a here and now real demand required. I think probably what's needed is to address some of the concerns that people seem to have, is to really engage with NHS England at the centre to look at what the future holds for the delivery of ophthalmology services, and what can the NHS continue to do versus what the independent sector can provide, and mapping out some of that demand and capacity modelling over the next few years. Is that underway, David, or are those conversations happening?
It's fairly patchy, I think it'd be fair to say, Alison. So I agree with you entirely, and I think to Ben, I think it links actually to Ben's point around the kind of sustainable strategic assessment of the long term of ophthalmology, as with other specialties as well. I think some of that can be done centrally, but I think actually quite a lot of that needs to be done at ICB level across local systems, making that whole integrated process real. I know, Alison, talking to you and Tim, there's some great work through GIRF, kind of looking at demand and capacity planning, trying to coordinate that more effectively. You know, be interested actually in an update from your side as how far you think that's got, but I know that's been challenging to try to get that, you know, kind of into ICBs. But I think, you know, we all collectively working with commissioners need to be doing more actually to have a bit of a proper look at this, so that it is actually structured. If we need to be commissioning new and different services to encourage new people into the market, then we should be looking to do that as well. So I think there's a lot to do. There are some conversations, but I think they're fairly early stages, Alison. And of course, you know, industrial action and all of the other kind of distractions for people, it does feel like everything's right. Okay, what do I need to do to get through today? Not really what are we going to be looking at 3, 5, 10 years hence.
Bushra, you got your hand up.
Yes, I will start with saying thank you very much. Very, very interesting. And for me, who only works in the NHS, sort of, you know, the broad view of how the services work in the private sector and collaboration and the as we have the same aim of getting the patients the ability to keep their vision and reverse any reversible blindness and all that. So very nice talks. My question is how sensitive, and it carries on from, you know, from David and Ben's and Anderson's question and what they were saying, this supply and demand. So we, at the moment, you know, post-COVID, the demand was we needed to get all these cataracts done because that was one of the things that was stopped, you know, more than other surgeries during COVID. So, and private sector is trying to meet that demand. How sensitive it is, because what I hear from colleagues, and again, I'm just quoting colleagues who may or may not be present here, the NHS is getting depleted of cataracts, whereas the waiting times are increasing elsewhere. So again, how sensitive this model of supply of health service basically is, where, you know, yes, the cataract need is dropped a bit, and now something else is increasing. And sustainability as well, because the big hospitals that are set up to provide these services, if they're not getting their enough share, or, you know, even the minimum to keep them afloat, let's say their cataract service, how are we working together? And because that is one of the things that most colleagues say, that the balance needs to be right, where what is going out into the independent sector and how much we should keep our NHS services afloat till a new model is developed. Thank you.
So maybe I'll start. So are you asking, do we think that healthcare delivery is susceptible of a model of supply and demand which is viable and sustainable? Is that what you're saying? I can tell you my view. I think up to a point, some of it can be, particularly, so cataract is a good example. Cataract surgery, most of it is predictable, standard, a defined unit. Many NHS hospitals already within themselves have a stream of cataract surgery work that's pretty standard and predictable, and the rest is isolated so that you can be efficient. So some aspects of healthcare can and I think should be subject to market forces, because this is what's going to make each actor be motivated to first be responsible and accountable to the service user, so to the patient, and secondly, improve their offering. But clearly you cannot have you shouldn't have a service that's solely based on supply and demand models, because then you end up with a situation like Ben alluded to. No one takes care of complex pediatric ophthalmology or elements of care that you cannot make function in a model like this. But for that, we require first these conversations, and also a higher level organization that will determine which part of the healthcare service is subject to these means and which aren't and are supported in that way. this goes back to the idea I put forward, that all of these things we do are means to an end. The end is what matters, is good patient care. And then we employ various methods to achieve that. And I think market forces works in certain circumstances, but it shouldn't also be thought of as a panacea. This is where people bring the example of the United States, where healthcare is the most expensive and not very functional for its costs. I don't know if David or Rebecca want to add something to that.
I mean, just to agree with that, Johan. I mean, I think, and there's a number of questions I see coming through around, the balance between market integration, and that's been a theme of the conversation. And I think it will always be difficult to get to balancing stability of kind of anchor institutions that can't fail with making sure that actually patient access and waiting times are as low as they can be, and whether the NHS tariff helps or hinders that, I think is an interesting question. I think one thing that I would quite like to see in place and hasn't really taken off. There's a conversation around ICBs having elective care boards, bringing acute, kind of secondary care providers together to be much more structured in their planning. I don't think that's really happened to the extent to which we'd probably want within those local systems. So it comes back to that kind of strategic commissioning conversation and freeing people up to do that, because I think we have to have a forum for those conversations at ICB level as well as the national conversations that take place.
Thank you. Ed Hubbard, you've got your hand up for a while. Hi, how are you?
Hi, Johannes, and thank you all for your talks. These have been very impressive, and I commend you on you're setting up a service which sounds to be set up in a responsible manner. Unfortunately, our own local experience hasn't been as good, and we have a number of providers who have set up that we've been unaware of, and seemingly don't have a good way of managing problems. So complications out of hours, there's been no one around. There have been offers of transferring patients across the country, and then we have, one of the biggest backlogs we have is medical retina patients, and we're being sent complications like cystoid macular edema, or diabetics have been under our care and then sent back to us with bad macular edema, and the collaboration is lacking. David has painted a picture of a utopia, and that sounds fantastic, and it sounds like that's working in Numedica nicely, but say other providers, it's not happening. We have another provider who publishes 0 complication rates, and we see the complications. So at the minute, the model isn't working properly, and there seems to be poor standards of care, accepting lower standards, and really independent providers need to be liaising with their local units as to how it's going to work, and for many of us it's just not happening at the minute, and patients are having a poor experience. I was hearing of patients who are being offered a 3-hour taxi ride to have their complication managed, and this is poor, and we really need to raise standards.
Ed, I don't know where you are in the country, but no, I do hear stories like this. That we are really keen that sort of thing doesn't happen. We talked about our partnership model, where we've got our partners who are really well connected with a local trust. I'm delighted with that, because that means we can get the synergy working really, really well together. And that's what we're sort of trying to aim for. And I agree, we've got to all get into a position where it comes up to the right standard. We're all doing the right thing. So that's all I can do, is I can encourage peers to do the same.
Yeah, I think that's right, Rebecca. I mean, just to add to that, as kind of the spokesperson for the industry, we're not apologists for poor care where there are, and this isn't a knights or knaves situation. This isn't an NHS versus independent sector situation. I think we all aspire for every patient to get the best kind of treatment. Clearly, where there are kind of issues locally that can be managed through the contracting process, then they absolutely should be. And again, I think that kind of joint working, needs to be formalised and structured in a different way. I think it does vary across the country, but I'm sorry that you've had a poor experience, locally, Ed. And actually, if there's anything I can do off the back of this conversation to kind of try and improve that in that system, please do let me know, because that's not something we want to hear.
I guess this is a good point of there needing to be professional communication and acknowledging that the responsibility of the provider and the clinician is to the individual patient. So that, yes, I strongly believe that competition does make things better overall. Even though competition will put you at risk of losing the competition, no loss is final. But it is a stimulus of working better. To that, the competition needs to be fair and needs to be focused for the benefit of the patient. So yet, perhaps part of the onus is on the independent sector provider to reach out via the ICB to ensure that there's a local ecosystem that can manage the needs of patients, and then each ICB region to decide how this is set up. And I think this is the time for that to be standard and not an exception.
Yeah, the emergency pathways, and we look at that at our MAC meeting regularly, actually. And I mean, it is normally part of every contracting sort of cataract specification anyway, to make sure that we can explain how that's worked and we've got the arrangements agreed. Going back to the training, the point made there, it has been really hard to get trainees. We've as you can hear, we've set it up. We're really behind it, and any help we can get, it's the local deaneries that we're sort of sometimes up against where we can't get trainees to come through. So we're here. We want to do more work. It's one of our missions to help support the junior doctors as they train through. So any help there would be fantastic. Ben, I don't know how you can help us with that.
I'm going to see Professor Sir Stephen Powis and talk to him about it in a few weeks.
That would be fantastic. Thank you.
So, Khalid, you have your hand up. Can you introduce yourself and please ask a question?
Oh, hi. Thank you. And it's been a really good session. So I'm Khalid Shahad. I'm the National Clinical Engagement Manager for orthopedics, trauma, spine, but also ophthalmology within NHS Supply Chain. And one of the things that actually is a real-term impact of some of this is we're working with trusts around the country around their contracted needs, and that's also lends itself to not just the products that they use, but also the kind of capital requirements and investment from industry that they have. The predictability of what's being done within an ICS is really important for those trusts being to establish what kind of kit they can get in order to modernize their services in terms of innovation and so on. And so it becomes really difficult when working with different regions to sort of like understand how best to serve NHS trusts in establishing new equipment from the same companies that are also being procured equipment and services from the private companies, because the two don't really tally together. And at the same time, it becomes really difficult for us to secure the best outcomes in terms of that annual spend for those trusts in their budgets as well. So it is something to bear in mind in that long-term planning of where cataract and IVT and glaucoma services are happening within the NHS has a real-term impact into what products they can actually secure within those NHS organisations. And that kind of led to my earlier question around the establishing of surgical hubs. This planning for the future in where surgeons are going to be practicing is really, really important in the NHS securing not just best price for products, but best investment from industry in helping them achieve those ultimate goals. So it's more of a point to make.
Thank you. So
it's just me, Bushra here. Do you mind just, this is a question that keeps coming up about the referral pathway. Just quickly, sort of, again, are these myths? Are these things that people just think of, that a preferential referral system is in place because of various reasons? Just a little touch, because that is a recurring theme with a lot of colleagues bringing that up. What's your view?
I guess you note this in the question Ed did about Specsavers and Numedic, and I guess Rebecca is best placed to answer that. Rebecca, can I ask you?
Yeah, sorry, is that the question you're asking? What are you asking, Bushra? Sorry.
If you look at the chat, so one of the questions
I missed that. Okay.
asked is whether there is a financial, so I'm just reading, is there a financial incentive for Specsavers to refer to Numedica? Absolutely
not. No. I mean, it's a completely separate business with its own governance. And I was talking about it only yesterday. I talk about it a lot. So obviously Specsavers Optical have to have their own assurance around competition law. They're regularly reminded. They know what the policies are, etc., etc. So that there's a continual communication on their side, obviously what's expected. From our side, obviously patient choice is everything. And as I was just describing earlier, we just want to be part of that patient choice conversation, as would Spa Medica, as would the trust. The patient needs to be given all the options available. And we always stress that there is absolutely no incentive whatsoever. I mean, we wouldn't be in business, would we?
Thank you. I guess we'll have one more question to Ben, and then we'll wrap up.
I mean, I'm not suggesting that you're making incentive payments at all, or any of the other companies are, but there is a situation that can arise where an independent sector provider might have arranged to have its post-op cataract check done with an optometrist who then gets paid, let's say, £50 for it. So the optometrist, when they see the patient, they know that if they refer it to one of the independent sector providers that does that, they will get the patient back and get 50 quid. But if they send the same patient to the NHS hospital, they will not get the patient back for a post-op check and 50 quid because the NHS hospital does it in-house. So it's not a direct bung, but it has, I'm fairly sure, an impact on referral patterns. Can we agree with that?
But Ben, how does that sit with the joint declaration of the Royal College of Ophthalmologists and the College of Optometrists that has asked for post-operative cataract care to be done in the community? NHS hospitals meant to send. I mean, my NHS hospital certainly does.
We don't control the money. So yes, it's great for it to be done in the community, and that should be probably funded, not by the individual company that's arranged it, but by the ICB paying for everybody to do that wherever they send them. I don't think that's the situation. I might be wrong.
Well, in Bristol, it very much is the case. The ICB arranges payment for community post-operative care delivered by optometrists.
So in which case, really, the system needs to change so that the hospitals start. Does your Bristol hospital eye patients, when you have cataracts in the Bristol Eye Hospital on the NHS, do they get their post-op care in the community as well?
Yeah.
So they get the same fee, whichever group they refer into.
Yeah. So the fee is administered by the ICB.
So that's excellent and sensible, and that would remove the sort of contention around this. I just don't think that's happening around the country. I think that's the exception rather than the rule, but I might be wrong. I mean, let me know if I've misunderstood that in some ways, if you've got any figures on that. But we've definitely there have been hospitals
everywhere, isn't it?
It is difficult, but I'm aware of some hospitals where they'd lost a lot of market share to the independent sector, and then they started paying local optometrists to do their post-op care, and suddenly the market share all came back again. And so it does seem, whether it's deliberate or not, it does seem to be driving referral patterns significantly.
To me, that's a good thing. The NHS was found a challenge. This specific group found a challenge, found a solution, and implemented it. And it's
so the effect of it, though, is essentially that it's let's say we're paying 50 quid. Previously, that was done in the hospital, and now 50 quid is leaving the hospital healthcare kind of financial package every time we do a cataract. So we're now, because we were doing it with nurses fairly cheaply, making some profit from that. So the hospital is now losing money because of this innovation and development, and it doesn't really free up any capacity in a meaningful way for us at least. But anyway.
Okay, without knowing what.
Sorry.
No, go ahead, Johan.
I thought this is a local situation that will require local addressing. I mean, I do agree that having the ICB administering this is, from the patient collective point of view, the best situation. I mean, I can only speak for Bristol because it's where I operate. To me, it seems reasonable. But should we find a different challenge, then it's for the actors in that group to resolve the challenge.
Ben, I agree. We should have a level playing field. I mean, it should be, it's patient choice, and it should be the same.
I don't think it's possible to have a level playing field, personally. But,
well, on the point you've just made, though,
choice, but,
on the point you just made about the post-op fee, that I without doing a big piece of work and understanding it, which I think is the ICB's role, to try and help that.
I take the point that we have overrun by 3 minutes. Thanks very much. I think that was interesting, and I hope this has met the expectations of the attendees, and hopefully there's a good learning here to be shared. The next meeting, Bushra, you gave dates, so I guess we might see you then. Thank you all very much. Thank you, David and Rebecca, very much for your time.
Yeah, thanks, Johannes, and everybody else. Just to say, it's good to have these discussions and bring it all out in the open. It's a beginning, so it's only an hour and a half meeting, but I'm sure we will be able to give opportunity either sides. We have to work together. Collaboration and this joint working is the way forward. But the rules, we need to make sure that we all sit down and make sure that it's a commonality of rules applying to everyone. And that would be another day. Thank you so much, everyone, for joining today. Thank you.
Thanks, everyone. Thank you.
Thank you.